Hello. We are going to continue with Murad Khan's lecture. Hi, sir. Do you have me? Do you have my... Okay, hello. Yes, your video is on. We have you. The topic of the lecture is cultural influences and challenges in suicide prevention in the Middle East. I'm going to make you co-host. You should get access to share your screen about now. Okay? You can start whenever you're ready. And as you know, I have to say two things. You can switch the language using the interpretation button for any participant who wants to listen to the lecture in Persian. We have online translation. And also you can write your questions in the Q&A bottom on the screen, and we can get to the questions at the end of the lecture. That's it. Okay, you can start whenever you're ready.
Hello, can you hear me?
Yes, we have your voice.
Okay, I'm just going to try and move my slides. I'll just put it up, and if it doesn't, I'll request you to operate it at your end.
Okay.
Final culture.
So I'm having some problems doing this. I wonder if you'd be able to operate it at your end, please.
Yes, absolutely. Do you have this now?
Yes, if you can put that on full screen.
Let me know when I have to go to the next slide.
Yeah. Good. And I'll let you know. I'll say next when it needs to be moved. So thank you very much for inviting me to this symposium. It's really fascinating to know that just a few days ago, Iran was being bombed by a country from far distant, the US. And there are US presenters in this symposium who presented in the symposium yesterday, as well as I heard a couple of them yesterday. So it is really fascinating. It is also very encouraging, despite what countries at the political level do when they decide to go to war and bomb other people, leaving death and destruction in the wake. There are decent people who can talk and continue to talk and contribute. So there is hope in humanity. I'm really glad that you were able to have this symposium. So thank you very much once again for inviting me. As you can see, my name is Murad Khan. I am based in Karachi in Pakistan. I am with the Brain and Mind Institute at the Aga Khan University. I'm a professor there. I've also been the former president of the International Association of Suicide Prevention. And I mention that because many of my views and my thoughts regarding suicide prevention, suicide research emanates from the discussions I have with the colleagues around the world. And IASP is a wonderful international organization. And if people who are on this webinar are interested, please look it up, the website, and do join. And there are lots of initiatives for young people, young researchers coming into the field. Okay, so I'm going to talk on cultural influences and challenges in suicide prevention in the Middle East, and what is the role of religion, stigma, and social norms that all influence and are subsumed under the umbrella of culture. So next slide, please. Okay, so the objective is really to understand cultural religious influences on suicide perception, suicide research and prevention, examine the role of stigma and underreporting due to this, explore some of the barriers to suicide prevention in the Middle East, highlight culturally sensitive approaches. Uh, but I want to just highlight a note of caution. One is that I will be using terms like Middle East, Eastern Mediterranean region, or EMR, and Muslims and Islam interchangeably. I'll tell you why. It's also important when you're discussing a large area like the Middle East, consisting of so many countries, that we should be making generalizations with a lot of caution, despite the fact that there are many commonalities between the countries of the Middle East or the Eastern Mediterranean region. There are also differences. And so when I make a statement about, say, domestic violence, it really has to be looked at with caution, because it's not the same picture throughout the whole of the Middle East. Obviously, there are variations from country to country. So next slide, please. So the Middle East consists of 22 countries that stretch from Pakistan in the east to Morocco in the west. And the color coding is their socioeconomic status. So in the blue, you have countries that are high-income countries like Saudi Arabia, Oman, and the smaller countries like Qatar, Kuwait, and Bahrain, very high GDP. Then you have the dark green like Libya, Iraq, all producing countries that are considered to be upper middle income countries. I don't know the current situation both in Libya and Iraq, if they're still classified as upper middle income countries. And then you have majority of the countries which are low middle income countries, of which Afghanistan, Pakistan, Iran, Egypt, and so on. And then you have low income countries in red, countries like Sudan, Somalia, Yemen, and Syria, Afghanistan. Next slide, please. So there are 22 countries. The total population of these countries is more than 750 million people. It is a population which is young population. So there is a youth bulge in the Middle East. Part of the reason is that the life expectancy is a little lower than in many of the high income countries, and therefore you have this youth bulge, but also because we have large families generally. The predominant religion of the Middle East is Islam, and in fact, all the countries are majority Muslim countries. 19 of the 22 countries have a common language, Arabic. 3 countries, Afghanistan, Iran, and Pakistan, have a different language. In Pakistan, it is Urdu. In Iran, as we know, it's Farsi. And in Afghanistan, it is Farsi in parts of Afghanistan, but also Dari and Pashto in other parts, which borders the province of Pakistan. These countries, because of the Islamic influence, they share traditions, they share culture, they also share food to large extent. The form of government in all of these 22 countries mostly are autocratic governments. So there are very few countries that have a representative democratic-based governments. In Pakistan, my country, although there is a parliament and there is supposed to be a democracy, it is a non-functioning democracy, um, and it is very autocratic. Unfortunately, Middle East throughout history has been a very troubled region because of the geopolitics as well as the regional politics. And as a result of that, the level of distress, level of mental anguish is directly related to what is happening at the national and the international level that affects the populations of these countries. Next slide, please. So a little bit about culture, as we're going to discuss the cultural influences. What is culture? There are many, many different definitions of culture. I've used one which I thought is simple. It is a system of shared ideas, systems of concept and rules and meanings that underlie and are expressed in the way that human beings live. So it is a system of shared ideas. We share that. We share the same values. We share the same um, way of looking at things, and how we interact with each other. So that is what really culture is, and is shaped by many different things. Next slide, please. Why is it important to study culture in suicide? Well, culture has a very important role generally in determining how people respond and view mental health and suicide. So, explanatory models of health, mental health, of suicidal behavior is largely determined by the culture in which we live. It influences the way in which we define and experience mental illness and mental health, our ability to access care and nature of the care we seek. For example, there is a lot of stigma about seeking care from mental health professionals because of fear of being labeled as being crazy or mad. So, culture determines that to a large extent. Then the quality of the interaction between the health professional and the patient is also determined by culture. Many cultures, physicians and doctors are given a lot of respect. In other cultures, perhaps the hierarchy is much more flat and there's a much more informal relationship. And then a response to the intervention or the treatment that we receive. How do we perceive that? How do we view the medications that are given? In Pakistan, for example, it's not uncommon for people to view or classify medicine as hot and cold. So they may say this medicine that the doctor gave me is very hot, or the medicine that the doctor gave me is very neutral or very cold. So all these concepts are determined by what are the cultural um, views on treatment, illnesses, and so on. So cultural variables have a far-reaching impact on suicide as a result of this. They shape the risk and the protective factors. Is there a lot of stigma attached to seeking help for suicidal behavior? Is it something that people talk openly um, or shun away? Is data collection difficult because it's a hidden problem? So culture really determines all of these things also. Next slide, please. So the cultural context of the Middle East largely, and here I'm making a generalization, because of being predominantly Muslim societies, family honor and shame are very important aspects to maintain family honor, and to if a person is shamed, then the ability to deal with that, particularly public shame, is considered to be almost a sin and difficult to accept. And largely, all these societies are collectivistic societies as opposed to individualistic societies, which we see in the West, of individual independence, individual expression, individual decision making, and so on. But in largely in the Middle East, societies are collectivistic, which means that there are large families, joint family systems, and decision making is also it's joint, or it's collective rather than individual. This also determines culture, also determines the gender roles of males and females, of how they should behave and how they should interact with each other, and things like how should they should dress up, how should they be seen in public, and so on. At the same time, there are a lot of taboos attached to mental illness, the concept of death, of mourning, of grief, um, and particularly suicide, because it is largely determined by the views of religion. So there are a lot of taboos attached to it, and taboo and stigma also determines whether we can seek help or hide from seeking help. Next slide, please. So, generally speaking, again, suicide rates in the Middle East are underreported, generally because of all of these reasons. And very few countries actually collect official data. Most of the countries, including my country, Pakistan, which is probably the most populated country in the Middle East, 250 million people. It does not have any official data on suicide, and we rely on WHO modeling, and WHO then gives estimates, and that is what we base it on. What has also been found of the research that has been done in these countries is that the hardest groups are youth, women, and displaced population. Now, yesterday, Dr. Cornwell, I attended his presentation on suicide in the elderly, and I think Dr. Diego De Leo will also be talking today later on. In the West, elderly have actually a peak of suicide, but we are finding that in non-high income countries, non-West countries, the elderly are actually do not have any such high suicide rates, but youth and women definitely do, as well as displaced population, displaced because of conflicts. And then there are lots of legal and religious implications of suicidal behavior, which also then gives rise to difficulty in data collection. And there's a lot of stigma if someone, say, makes an attempt to seek help, or when there is a suicide, for the authorities to certify that as a suicide and not misclassify that as maybe an accident or a homicide. Next slide, please. So in about half of the countries of the Middle East, suicide attempts are still criminalized, which means you can be charged under law, or because of Sharia law, because of Sharia operating in these countries, you can be penalized for this. The recent country that has decriminalized suicide in the Middle East is Pakistan, and other countries outside Pakistan include Malaysia and Ghana and Kenya. And there are plans afoot of the 22 countries that still have suicide attempts as criminal behavior to decriminalize this. Very few countries have national suicide prevention strategy. Iran is one of them, and I had the opportunity and the privilege to visit Iran in 2016 as a WHO consultant to review the suicide prevention strategy, and I can tell you it was extremely impressive. Then there is poor access to mental health services. Mental health services are poorly developed, and particularly in the rural areas of these countries, access to mental health care is very, very difficult. And people have to travel large distances, long distances to seek help. And there is limited training, limited exposure of health workers to generally to mental health, but more particularly, more specifically, to suicide risk assessment. Next slide, please. There is a very strong prescription against suicidal behavior in Islam. And of all the monotheistic religion like Christianity, Judaism, Islam goes much further to declare suicide as a major sin, Gunah al-Kabira. So it is a major sin in Islam, and it says very clearly in the Quran that do not kill yourself. And the basis of this is that life is a gift from God, and only God has the right to take life at a predetermined time. And if a human being takes his or her own life, then he or she is interfering with the work of God, and that becomes a major sin. The second important aspect is Muslims are never ever supposed to lose hope. No matter how dire the circumstances, they must never lose hope, and they must have faith, and therefore giving up and dying by suicide is again seen as going against the will of God. There are obviously a lot of social and spiritual consequences because of this, and religious beliefs can afford protection. Suicide rates generally in Islamic countries are less than in non-Islamic countries, but also they become barriers to help seeking, because the person who may have made an attempt and survived may feel they have done something that against Islam, that is against God, and therefore I will be punished. So the guilt increases many times, and that becomes a barrier to help seeking. Next slide. So suicidal behaviors are deeply stigmatized. They're hidden or misclassified in many countries, and therefore we do not know the true rates. Family fears legal, social, and religious consequences, particularly in countries where it is criminalized, and therefore underreporting to police and health official is not uncommon. Next slide, please. Um, Middle East is, like I said, an area where lots of conflicts are going on. There is an active conflict going on in Palestine. We know the situation in Gaza and in the West Bank. Syria has just come out, but it's still very unstable. Yemen, relatively stable now, but still under attack. Um, we've seen what has happened in Iran very recently. Afghanistan has suffered for probably 40 years of conflict and suffering as a result of that. And in Pakistan, low intensity terrorism and other violent acts are still continuing. And at the moment, there is huge state repression because of the interference by the establishment, the military in Pakistan. So anyone who makes a statement against the government, even a small tweet, um, is threatened. So living under such circumstances, these extreme circumstances, obviously cause a lot of distress, mental distress, that then gets translated into all sorts of health consequences. The extreme form of which is obviously suicidal behaviors. And due to internal as well external migration, due to these conflicts, there is cultural dislocation, and people lose their social support systems, they lose their points of reference, and it again increases the distress. Next slide, please. There are differences in the two genders and the effect of the culture in on the two genders. Women generally, again, I'm making a generalization, have restricted autonomy in the Middle East. Obviously, it varies from country to country. In some countries, for example, Iran, as we know, covering of the head by women is compulsory. In Pakistan, it is not. In Saudi Arabia, women could not drive until recently. In other countries in Iran, women can drive. So there are restricted autonomy determined again by the culture. The second important thing is throughout the Middle East, the rates of domestic violence are very high. And then there are honor related pressures on families, the extreme form of which is honor killing. So that's so called honor killing because the women may have been deemed to have transgressed and therefore is just death is justified. For men, it is the financial situation, the socioeconomic situation, and men generally have difficulty in expressing their emotions, and therefore this leads to build-up of tension within them. Again, suicide amongst the youth and the women that I talked about earlier, as opposed to the older people, are largely determined by the control and the oppression the youth and the women feel in the Middle East. Next slide, please. We did a situation analysis recently, and what we found is that obviously this was the Eastern Mediterranean region, that about more than 40,000 suicides happen every year in the Middle East countries. Age standardized rates of 6.7 per 100,000, more males than females, more young than old. But if you look at the marital status, then there are generally both male and female. There are more single than married people. But if you just look at the women data, there are more married women than single women, generally speaking. The methods that are used are hanging, pesticides, use of firearm, and self-immolation. And the psychiatric diagnosis, not unsurprisingly, is number one is depression. If you look at the box on the left-hand side, the last one, the residents in the Middle East, there are about 66% of the people who live in low middle income countries of the total population of 750 million. And suicide in this population contributes 77%. So of the 41,000 suicide, 77% of the suicides are by people who live in the low middle income countries of the Middle East. So socioeconomic status, poverty, unemployment, and suicidal behavior have a close correlation. Next slide, please. My colleague from Rafsanjani University, Professor Mohsin Razian, came up with this very nice model about suicide in Middle Eastern women, and he calls it the four cruel M's. The method that is chosen is self-immolation, hanging in firearms. He's just talking about women in the Middle East. Depression. The second is the mental distress. The third is masculine role, the attitudes, the society that is largely patriarchal, and the discrimination between men and women, where men are given all sorts of privileges and freedom, and women have restrictions. And then marriage. He said marriage was a risk factor for poor mental health and suicidal behavior. Uh, uh, there are lots of forced and arranged marriage, and of course, domestic violence. So this was published in Crisis in 2010. Next slide, please. I'm just going to elaborate a little bit more about marriage and Muslim women. Although these countries are not in the Middle East, but nevertheless, they're Muslim countries, the four Muslim countries. If you just look at the number of women suicide, so the denominator is women suicide. So in Bangladesh, more than 3,000 women data, 71% of these women were married. In Pakistan, 60%, in Iran, 68%, and in Indonesia, 70%. So the majority of women who were dying by suicide in these countries appear to be married. Next slide. And they were young. So it does appear, if you look at the data in these countries, in the Middle East, that young married women are overrepresented in prevalent studies of common mental disorders as well as suicidal behaviors in many of the Middle Eastern countries. And what is emerging now is that unlike the West, where it is protective, and we heard that yesterday from a speaker, that marriage being in a, I think it was Dr. Fazil, Sina Fazil, who said that being in a partnership, being in a relationship, being married is a protective. In fact, in non-Western countries, marriage for young women appears to be a risk factor. Next slide, please. And there's an important point that needs more exploration. And some of the associated factors are these: early marriage, arranged marriage, pressure to have children early on in the marriage, economic dependence on the husband. Many times, because of the low age of marriage of females, there's curtailment of education. Domestic violence rates are very high. All this leads to high psychological distress. Next slide, please. For men, the issue of izzat and honor is very important, both personal as well as for family, particularly if they cannot provide for the family. Failure in life is seen as a stigma, and obviously this is related to the kind of employment they have, or whether they are employed or underemployed, or they have a good paying job. Next slide. So very briefly, what are the clinical implications of these findings? Next slide. I just want to touch on these clinical implications. It is important that when we interview people in our clinics, those of us who are clinicians who see patients, that we keep in mind the cultural and the religious background of the person. Alcohol, for example, is a very strong mediator in suicidal behavior in the West. Although it is banned and it's not part of the social milieu in many of the Muslim societies, alcohol is used and is available in almost all the countries. So officially, you may not have bars and pubs and so on, but it is available and people use it, and we all know it. So it is important to inquire about alcohol when you are interviewing people. Confidentiality is very important because people are very very apprehensive about stigma. It's important to avoid religious stereotypes. Someone looking religious may have a beard, may be wearing clothes that are non-Western. We should not assume immediately that they do not suffer from suicidal ideation or suicidal thoughts because they are haram, and therefore we must not ask about them. So we must inquire about these things. Next slide. So females always inquire about domestic violence. Females will not volunteer this information. It is important to ask them. Ask about religious restriction. What kind of restrictions do you have? And is it imposed on you by the others, or you're doing it willingly? In Pakistan, like I said, hijab is optional. And so when I interview women who may be coming to see me for depression and anxiety, I ask them, if you've taken the hijab, is it because your husband or your in-laws have forced you to do it, or you have done it by your own will? And many times they do say that it is because my husband does not want me to be uncovered, and that's why I have to do it. I don't like it. It's important to ask about the relationship of the woman with the in-laws, particularly with the mother-in-law, and particularly if it is a joint family system. But also, interestingly, ask the woman, if you are interviewing her, the relationship of a husband to his mother. That largely determines the quality of the relationship the husband will have with his wife. Next slide, please. I can't elaborate on this, but maybe some other time. Males always inquire about anger and temper issues. And again, this is not something that volunteer ask them, because many times this is the thing that leads to violence towards female. Socioeconomic difficulties and other stresses that they may be facing, and the use of alcohol. I'm reiterating that. Next slide, please. It is important, and again, I've just to repeat myself, that despite the Islamic background, it is important to ask about depression, ask about suicide risk in the clinical setting, and where a person has a faith-based approach, they believe in spirituality, they believe in religion, to use this to help the person as in the management of whatever they may be suffering from. And so it's not just the biopsychosocial approach, but it should be really the biopsychosocial spiritual approach, appropriately used for people who have a religious background. Next slide, please. Next slide. Yeah, so difficulties are, it is really difficult to study suicide or suicidal behavior where it is so culturally, socially, religiously condemned. And many researchers do have this problem, and that is why there's so little research coming out of the Middle East, generally speaking. Data is not available, and because, without good research evidence, it's difficult to come up with evidence-based prevention strategies. Next slide. But this is kind of research we need. We need good epidemiology. We need local data. We need to understand what is the meaning of suicide in settings where it is so strongly religiously condemned, culturally condemned. We need psychological autopsy studies. These are studies that look at the behavior of the person in the days, weeks, and months preceding the act, and highlighting the risk factors that the person may have. And we need to study the interaction between religious and cultural values and the socioeconomic conditions and how they interplay with each other, and when does the deterrent, the religious deterrent and the cultural deterrent loses its effect, and the person then starts to progress on the suicidal pathway. Next slide, please. Prevention programs must be evidence-based, and it is important to come up with local evidence. What may work in, say, Holland or the UK will not work in Iran or Iraq. We have to look at religious sensitivity, the issue of guilt and punishment versus forgiveness, and where applicable, we should use faith-based approaches to strengthen the positive aspect in the person. Next slide. These are some of the challenges. For males, it is important, particularly in low-income countries of the Middle East, to improve social conditions, give them employment. The upbringing has to change, particularly the attitudes towards female, that really has to undergo a change. And for females, it's imperative that they receive education to the highest level that they can, because through education, they will have access to many other things which will improve the self-confidence, self-esteem, and which will really truly empower them. Next slide, please. For suicide prevention, important to engage religious leaders in prevention as well as education. We need to look at community-based mental health models rather than health facility-based. It's important to use local language, local metaphors, and frame it spiritually, and use storytelling, positive cases where people have overcome difficulties and adversity, or even made an attempt and survived, and how they have turned their lives around. Next slide. And there's some good practices in Lebanon, crisis lines in Jordan, integrating mental health in the refugee camps. In Iran, like I said, I saw it, witnessed it myself. The National Suicide Registry development is extremely amazing. And in Pakistan, trying out school-based suicide prevention programs. Next slide. Yeah, just go on to next slide. So recommendations are, it's important to decriminalize suicide attempts in countries where it is still criminalized. We need to really invest much more in mental health infrastructure, train health and religious leaders collaboratively. We need to collaborate with them. It's imperative we put in surveillance system. We have good, robust, valid data. That is the basis, the foundation of any suicide prevention strategy. And we must do culturally informed research. It is very important to have a research strategy and not the research to be opportunistic. See what is applicable, what are the needs of a particular setting of a particular country, and what kind of culturally based research that we need that will inform prevention policies. Next slide. So in conclusion, suicide prevention must be grounded in cultural understanding. Silence and stigma alone will not be solved by just raising awareness. There have to be structural changes that we need to address. And we need to collaborate across many different sectors. Next slide. And I just want to leave you with this quotation from Holy Prophet, peace be upon him. And thank you very much for your attention. I'm sorry I've gone over time. Thank you.
Thank you very much for that very relevant and valuable talk. Unfortunately, we won't have time for the Q&A. We have to move on to the next, but we can, if it's possible on your side, we can share your email with the participants and they can ask follow-up questions from you through that.
Sure. Absolutely.
That would be.
Thank you very much.
Thank you.